Welcome, everyone. Thank you so much for joining us for CAEP Grand Rounds. We're excited to have you all today. And before we get started with our topic at hand, we have a video from the original emergency medicine nerd, Dr. Ian Steele.
Hi, everyone. This is Ian Steele, Editor-in-Chief of CGEM. I'm here today to remind you that CGEM is not just for research nerds. In fact, CGEM is designed for frontline emergency department clinicians and is very, very cool. Here are a few clinician features that you might not be aware of. First, while we do have original research articles, we make it easy for you to get to the bottom line. Every article has a clinician's capsule that gives you 4 brief bullets, including why this article is important to clinicians. As well, we continue to have the ever-popular case reports that give you interesting cases and images with up-to-date tips on diagnosis and treatment. Relatively new is our Just the Facts series, edited by Paul Atkinson. These are focused 3-page summaries of cutting-edge tips for common problems by Canadian experts. Really good. Finally, the major journals like New England and The Lancet publish the big practice-changing studies. We introduced our Need to Know Journal Club series, page-and-a-half structured reviews by Canadians that rate the articles and give you a simple bottom line on what you need to know. Very cool. Look for the January issue of CGEM coming out next week. Bye-bye.
Thank you so much, Dr. Steele. You'll notice behind me, I have a big stack of my CGEM journals, which I refer to often. So again, thank you everyone for joining us for CAEP Grand Rounds to discuss the dual public health emergencies addressing Canada's opioid epidemic during COVID-19. We're thrilled with the panel who have agreed to come and speak with us today. And thank you very, very much for the panelists who will join us at the very end for question and answers as well. Before we get started, CAEP would like to acknowledge that today's Grand Rounds are being hosted on the unceded and unsurrendered territory of the Algonquin people, traditionally known as the Anishinaabe. Algonquin people are the original inhabitants of the wide swath of territory along the Ottawa River. In Algonquin culture, it's appropriate for guests to acknowledge the hospitality of their hosts when entering their territory. With this tradition in mind, CAEP respectfully thanks the Algonquin people for hosting us on their ancestral lands. Megwech, thank you. A few housekeeping notes today. CAEP Grand Rounds is hosted by me, Elizabeth Scholdice, and by Justin Coe today. Justin is joining us in the early 8 a.m. hour in BC. As we host Grand Rounds, there are a few things that we need to note. One is please save your questions to the end. You can text your questions in. You don't need to remember them for the end, and then we'll try to collate them and get to them when we have the panel discussion at the end. There is a Twitter hashtag, CAEP Grand Rounds. I imagine that this will generate a lot of discussion. So please keep the discussion going on Twitter during and after. Please don't forget to fill out your evaluations. Again, this is a new time for Grand Rounds, 11 o'clock in the morning. Please feel free to give your feedback on that as well. I went to a meeting recently and it was acknowledged that we are all in each other's homes right now. I'm in the clinic space, but oftentimes people are at home. I'd like to acknowledge that kids and dogs are welcome. If there are disruptions, we understand. And thank you for inviting us into your homes. Without further ado, we'll get started. So first, I'd like to acknowledge our conflicts of interest. There is only one conflict of interest, and that is our pharmacist panelist, Mark Barnes, has a conflict of interest he received some funding from the intranasal naloxone company. There is only one in Ontario, and that's funding to do advocacy work for naloxone. Other than that, there are no conflicts of interest. With all of that said, I think I've covered off all of our housekeeping. The very last thing I'll say is a heartfelt thanks to the CAEP staff who've helped to get this together and to our production team. This is not a small feat to get this coordinated across the country. So thank you so, so much to Christina, Gail, Shanna, and everyone else at the CAEP office for doing this for us. This is an incredibly important topic, and we're thrilled that we're able to get to present National Grand Rounds. So I'll hand this over to Justin. A brief introduction about Justin. Justin is a PGY4 at the University of Saskatchewan. He is now currently doing his addictions fellowship at the BC Centre for Substance Use. Justin is an absolute superstar. He was the first author on the CAEP opioid position statement, which was a gargantuan piece of work that he took on. He is a champion for social justice and someone I look forward to watching his career develop, because Justin is just bound for great things. Thank you, Justin, for all of your hard work and for everything you do for your patients across the country. Over to you.
Thanks, Dr. Schuldeis, for that introduction. I'm really happy to be joined by everyone from across the country for Grand Rounds today. I'll be just going over our learning objectives quickly. By the end of the session, we hope that you'll be able to recognize barriers to emergency care faced by people who use substances. You'll understand how to use buprenorphine in the emergency department setting. And finally, you'll be able to describe the impact of COVID-19 on the opioid epidemic. I have the pleasure of welcoming Petra Schultz as our first speaker today. Petra represents families with lived experience in Health Canada and CCSA advisory committees. Through the lessons learned from her personal experience and by sharing her son Danny's story, Petra has become an advocate for drug policy reform to reduce the harms associated with substance use. She believes that substance use is a matter involving human rights and health, which must not be criminalized. Petra, I'll turn it over to you. Thank you.
Thank you very much for the invitation and for the opportunity. And I'd like to thank all of you for all you do. Here highlighting some of my formal engagement experience that Justin already mentioned with the federal government, provincial government, as well as with the Canadian Centre for Substance Use and Addiction and various policy consultations. If you're ever looking at engaging people with lived and living experience in research and policy, I would encourage you to consider some of these points, which are not the topic of today, but I'd be happy to answer questions on this. Our learning outcomes for today are as follows. Looking at personal narratives and their value, the challenges faced by families, recognizing the importance of engaging families, identifying what emergency departments can do, looking at the role of harm reduction as well as language. Why do we share our stories? We share our painful stories to open hearts, and we hope that opening hearts will lead to opening minds. So much what is happening in drug policy and practice in this country is based on morals and beliefs rather than evidence, and we're hoping to change that. It's not easy to speak out and because of stigma, but here's a list of some other organizations in addition to Mom Stop the Harm that do. My son, Danny. Our youngest child, Danny, died from accidental drug poisoning in 2014. He was 25 years old. Danny was in recovery when one more pill, which he thought was a fake OxyContin, but in fact was fentanyl, took his life. He was one of the early victims before fentanyl made the news and before there were health warnings. What worked for Danny was opioid agonist treatment combined with counseling. What did not work was both he and we were keen to have him drug-free. And he did not stay on methadone long enough to be stable. I have since learned that opioid substitution is not just another drug, but vital medication that allows people to live in recovery and stay alive. For a while, it seemed like we had the old Danny back. He looked like a successful young man on the outside, but inside he was still struggling. His substance use started as a way of dealing with severe social anxiety, and there were other risk factors, such as a learning disability, being gay, working in an environment where drug use was prevalent. One of the most significant barriers to providing more effective supports is stigma, including the structural stigma of institutions. It is a stigma and criminalization of substance use that causes people to use and to die alone. The lack of health warnings and the rising number of deaths and our experience with the health system led me to speak out and find like-minded individuals. Lorna Thomas and Leslie McDean and I, we founded Mom Stop the Harm in 2016. Today, we have about 1,800 member families across the country, most in BC, Alberta, and in Ontario. Families try their best to support their loved ones, keep them safe, alive, and connect them with health services, but families face a number of challenges. We try to navigate a fragmented health system. We try to find care for our loved ones, and we try to figure out what will work and what is evidence-based. We face social isolation from family and peers because of the stigma of substance use. We have to care for loved ones who have lasting health effect from substance use. And we face economic strain, including lost time from work, paying for treatment, paying legal costs, paying dealers in some cases, and ultimately paying for funerals. Many families are coping with grief and trauma, and often complicated grief, which lasts longer, is more intense, and more debilitating. From all this, we experience adverse health effects. Families have a central role and need to be part of the solution. Evidence-based interventions targeting families can improve health outcomes, result in better addiction treatment, and even prevent substance use. Individuals and families require honest, timely, and relevant information about the risk of substance use, harm reduction, and treatment options. Don't perpetuate the myth that abstinence is the only way to go. Families must be treated as partners in keeping people safe and in achieving treatment success. Now, this is noting that, of course, it depends on patient consent and the relationship with the family. In emergency departments, you are in a really unique position. You have access to patients who might otherwise avoid the health system, and you can connect. Your role is life-saving, not only in the moment in the ER, but also in the future. As noted before, include the family, and don't assume the person is drug seeking. Treat pain appropriately. Provide harm reduction supplies, or if not possible, information. Inform individuals and families about evidence-based treatment options and where to turn. Whenever possible, make sure rapid access to treatment is available, and create a system to follow up and see what has happened to people. And whenever possible, employ people with lived experience in your ER. You see a photo here from the ARCH team at the Royal Alexandra Hospital, and Catherine Dong is in a very good position to speak about that. If you can only change one thing today, make it this one. Don't let anyone leave your emergency room without naloxone. And I'm saying naloxone, easier to pronounce for me. Families are often first on site after an overdose, and it's so important to get that into their hands. And evidence has shown that wide naloxone distribution can really reduce overdose deaths. Danny was as safety conscious as he could be, and he always bought new needles. But the day he died, he was home alone, so nobody could assist him when he overdosed. I can't tell you how many times I imagine myself finding him in time with a naloxone kit in my hand. I can visualize what I would have done, but never got to do. When we looked for help from the health system, we were told not to enable, to wait for him to be ready after he hit rock bottom. Nobody talked about the risk of relapse, harm reduction, and what we could do to increase his chances of survival. I learned about naloxone after he died. You have a chance to make a difference and make sure other families don't have to live with my regret. One of the greatest risks of overdose is when people are alone. So you are have a unique position to inform people about ways to stay safe, such as supervised consumption or overdose prevention in your area, sources of harm reduction supplies, as well as a new overdose prevention hotline and 2 apps I want to draw to your attention to. The best site, in my opinion, is Toward the Heart from BC, and this quote is from their website. We must also remember that most people who use substances don't do so problematically, but yet they are at the same risk of overdose, and we have to keep people safe. We persistently fight stigma at all levels. A good place to start to fight stigma is by changing the words we use, including in patient charts and in conversations with each other and in health policy. Use neutral, accurate terminology and employ a person first principle. The Health Canada website as well as CCSA websites provide really good information on language and stigma. Sadly, we know that many people who suffer an overdose don't recover. Help families navigate substance use related loss, and don't be afraid to ask about organ donation. We look for meaning in these difficult times when we have our tragic losses, and we would have donated Danny's organs had we had a chance, and many of our families have. These are some grief resources on our website you can share and let families know that they're not alone. This is a knowledge translation project that came out of the research project on mother's advocacy. It's a tool for you to use and share. Once again, it's meant to reduce stigma, and it's another way to use personal stories to share to change the narrative. In closing, I'd like to leave you with this message. I'm glad you're here, but this is also the message I'd like you to give to people in your ER. When a person who uses substances presents to yourself, maybe at the end of their shift in the middle of a pandemic, remember how hard it is to come forward and ask for help. Welcome the person. Tell them you're glad they came, that you want to help. Keep them safe, keep them alive, and I guarantee you someone's mom will thank you for that. Thank you very much.
Thank you, Petra, for sharing Danny's story and for the advice and for your leadership and advocacy. We really appreciate your time. As a reminder to the audience, we will be taking questions during our question and answer panel at the end, and your questions can be posted in the chat or texted to us as well, and we'll do our best to get through all the questions that are submitted. Next up, Dr. Clayman will be presenting on the use of buprenorphine in the emergency department. Dr. Clayman is an emergency and addiction medicine physician at St. Michael's Hospital in Toronto, an assistant professor at the University of Toronto. Her academic interests include medical education and improving the quality of care of marginalized populations. Dr. Clayman, the floor is yours.
Thank you, Justin. It's such a pleasure to be here, and thank you so much for inviting me to speak on such an important and timely topic. And a special thank you to Petra for sharing her deeply personal story. I'm going to tell you about a story that changed my practice. About 2 years ago, I saw a patient in the emergency department who came in following a fentanyl overdose. He received naloxone in the community and a bit more in the emerge, and basically slept my entire shift. At the end of my shift, he was awake enough to engage in conversation and enough to be discharged, so we had a brief talk. He had come in from Northern Ontario to Toronto looking for resources, trying to get help for his fentanyl use. I told him that I worked in the Rapid Access Clinic for Addiction Medicine, or the RAM Clinic, and that he was welcome to come see me the following day. He was discharged. We gave him a naloxone kit, told him about our safer supply injection kits at the front of the emerge, and he left. The next day, my clinic was quite busy. I actually didn't realize until later that night that he never showed up. A few days later, I was back in the ED, receiving a handover from a colleague after a very busy night shift. She was stressed and exhausted after having multiple resuscitations, including that of a young man who had come in following a fentanyl overdose. I didn't think twice until I looked at the board and noticed the name. I walked over to the room and saw that it was the same patient I'd seen just a few days prior who did not show up to my clinic. I don't get very emotional at work, but I really teared up this time as I saw his body lying there. In retrospect, our vision is 2020. And although it's impossible to know if this would have made a difference, I really wish I started him on buprenorphine or even provided him with a prescription. I really felt like I should have known better as somebody who'd been working in our emerge and in addiction for several years. Death due to opiate overdose is at an all-time high, as you'll hear, driven by the illicit fentanyl supply that is contaminated by benzodiazepines, high levels of caffeine, and other stimulants. This is compounded by the isolation and lack of resources that people who use drugs are experiencing right now. Opiates, as you heard, are killing young people and causing a huge burden on emergency care physicians as we stand by and watch our patients die. This is despite widespread harm reduction initiatives across the country, including injectable opioid agonist therapy out west, safer supply hydromorphone tablets in Ontario and various other provinces, robust take-home naloxone programs, and safe consumption sites. And of course, long-acting opioid agonist therapy with methadone, buprenorphine, and long-acting morphine. As emergency physicians, we have a critical role in this opiate crisis. Yes, of course, promoting harm reduction practices, but we also have a role in starting patients on life-saving medications, especially buprenorphine. Patients are used to being treated with an adequate, stigma-based approach to care. An idea that addiction is not in our wheelhouse and that we should leave it to the experts. But I'd argue that we are the experts. We see so many patients with opiate use disorder. I hope this talk empowers you to initiate ED buprenorphine if you're not doing so already. It is easy, safe, and standard of care for opiate use disorder and opiate withdrawal in the emergency department. Over the last 5 years, the literature has grown exponentially, and the evidence for ED bup is strong. It is superior to clonidine to treat opiate withdrawal. It increases engagement and follow-up with addiction services. It reduces illicit opioid use, is cost-effective, and most importantly, is the best evidence to prevent opiate overdose. Just like methadone, it is dosed daily, observed at the beginning, and creates a steady level of opioids in the system that prevents the cyclical withdrawal and intoxication that people who use drugs experience when they use high-potency, short-acting drugs like fentanyl. It is a combination medication with naloxone and buprenorphine. Buprenorphine is the active ingredient. Naloxone is only there to prevent IV use. So if buprenorphine is taken correctly, which is sublingually, the naloxone has no bioavailability and no effect. If it is crushed and injected, the naloxone will take effect, as you know, and precipitate a withdrawal. This is not to say that buprenorphine is not misused, but it is very rarely contributing to overdose. It is a partial agonist, which means that it has high affinity for the opioid receptor, but low intrinsic activity. This is good and this is bad. So on the plus side, it reduces overdose. This is because it has such a high affinity for the opioid receptor. At a steady state, at a dose of 16 milligrams, 70% of the opioid receptors are blocked, leaving only 30% for other full agonists to bind. It also has less side effects than other opiates. This includes weight gain, suppression of the testosterone axis, and constipation. And very importantly, it has a ceiling effect for respiratory depression. So it doesn't matter how much more buprenorphine you give, it is very unlikely that you are going to decrease somebody's respiratory rate. This can be attenuated by concurrent benzodiazepines and alcohol. So if you are going to use it, just use lower doses. On the negative side, we do have to be very careful about precipitated withdrawal. This is because buprenorphine has a low intrinsic activity at the receptor. If given too early when a full agonist such as fentanyl or other opiates are still bound, it will displace the full agonist and reduce the activity at the receptor, causing withdrawal. The withdrawal is difficult to treat, and the chances are the patients won't want to start on buprenorphine again. With this in mind, there are two options in starting buprenorphine in the emergency department. The traditional way is to provide up to 12 or 16 milligrams on day 1, depending on your local protocols. In our emergency department, we generally start with 4 milligrams and give an additional 4 milligrams Q1 hour as needed. In this case, you have to be sure that the patient is in adequate withdrawal and has been an adequate time frame since their last opiate use. Again, we start at the lower dose, the 2 milligrams, if we are worried about respiratory depression due to benzos, alcohol, or severe hepatic disorders. Generally, a CAO score or a clinical opioid withdrawal score greater than 12 is a good place to start. And I've inserted it here, and I don't expect you to be able to read everything, but it is quite easy to apply, much easier than the CWA protocol, and it is quite less subjective than the scale for alcohol withdrawal. Timing is a little bit more tricky. We used to say 6 to 12 hours since the last short-acting opioid would be a safe time to start buprenorphine. However, with fentanyl now, we are seeing precipitated withdrawal at shorter periods of time. So recommendations are 24 to 48 hours since last fentanyl use. The more contemporary dosing schedule is called microdose induction. This protocol is useful for anybody that is not in withdrawal or anyone who you're worried about precipitated withdrawal. The downside to this is that it can take up to a week to reach full therapeutic dose. So in this case, at day 7, the patient will receive 12 milligrams as opposed to the traditional initiation where the patients can receive 12 milligrams on day 1. Here's an example of a 1-week prescription. This means that in the emergency department on day 1, when you see them, you only have to provide 0.5 milligrams sublingually. Day 2 is 0.5 milligrams BID, and then it is increased as so on. You can give the first dose in the emerge, send the patient home with a few doses to take at home until they have follow-up in the rapid access clinic or any other addiction service, or simply write a prescription. Whatever you do, it's going to be better than doing nothing. We know that patients who are not started on treatment in the emergency department are less likely to attend an outpatient appointment like my patient. If you prescribe buprenorphine, you're giving them a chance to get to that appointment and stay on treatment. Unfortunately, my patient did not get to that point. And now I offer buprenorphine to all my patients who come in with opiate withdrawal or after an opiate overdose. The main barrier to my patient is that I was worried about precipitated withdrawal, but I could have sent him home with a script. I could have sent him home with some take-home doses. Follow-up, of course, is essential. By now, there are addiction clinics all over the countries, many offering virtual care appointments. And if they're not, family doctors are in a perfect position to continue buprenorphine. In fact, long-term healthcare outcomes in patients who receive their opioid agonist therapy and their primary care from a single physician are much better. If you want to learn more, there are tons of resources out there. Most provinces have clear clinical guidelines that you can easily Google, and there are several protocols for ED initiation of bupe that can be adapted to your local needs. If you like watching videos or listening to podcasts, Canadian resources include EM Cases and Quick Hits. There's also a great 20-minute video on ED bupe by Ruben Strayer that is worth a watch on EMU 365. I hope this talk is giving you something to think about and that you will start prescribing buprenorphine if you haven't already. If you need any help getting this started in your emergency department or looking for some protocols, I'm happy to point you in the right direction. Thank you very much.
Thanks, Dr. Clayman, for sharing your expertise with us today. And CAEP is also working on building some resources for providers across the country that we'll be able to share in the near future. Finally, I'd like to welcome Dr. Isabel Miles, our last speaker for today. Dr. Isabel Miles currently practices as an emergency physician and addiction physician within the inpatient consult service and outpatient clinic at St. Paul's Hospital in Vancouver. She aims to continue improving care for people with substance use disorders through education, development of clinical guidance documents, and quality improvement projects. Dr. Miles, please go ahead.
Thanks, Justin. So today I'll be talking about the impacts of the current COVID-19 public health crisis on our second crisis, which is the opioid overdose epidemic. So since 2016, Canada has been experiencing an opioid overdose epidemic, with mortality rates from 2019 improving but remaining quite high. Most overdose deaths involved high-potency opioids, such as fentanyl, and 50% occurred in private residences. Increased risk of fatal overdose has been linked to the rate of non-fatal overdoses prior to that fatal overdose and the number of emergency department visits. In fact, 1 in 20 patients experience a fatal overdose within 1 year of their index visit in the emergency department. So to reduce this risk of overdose, we advise on harm reduction strategies, such as accessing supervised consumption sites. As Dr. Clayman said, we encourage initiation of OAT, but unfortunately, it still has some limited accessibility for some. Unfortunately, the fight against COVID 2019 has put further barriers and restrictions to those strategies, with the advice to reduce the spread of the virus, such as self-isolation and reducing in-person healthcare visits, in direct opposition of those strategies. This was clearly evident in the reduction in supervised consumption visits in BC. So it's unsurprising there has been a significant rise in overdose deaths in 2020. In the first 6 months, data showed a 50% increase relative to the same time period in 2019, with the largest increase in overdose deaths in the months of April to June. This actually represented the highest quarterly count since the start of the epidemic in 2016. COVID has had a number of other impacts on people who use substances. Interruptions in the drug supply has led to unpredictable toxicity with frequent adulterants and high potency opioids, as well as concerns and fears about consistent availability. Lack of housing significantly limits the ability to properly self-isolate. Due to concerns over AGMP, initially there was some fears around the risks of responding to an overdose. Accessing care such as harm reduction supplies and even opioid agonist therapy could be limited due to restricted hours and the necessity at times to present in person, including daily visits to pharmacy. These patients have often comorbidities who are at higher risk of more severe COVID, such as COPD, and are at risk of destabilization in the context of promoting self-isolation, such as depression. A lot has been done to mitigate some of these harms, including some of our panelists contributing to some of these guidelines. But we've regardless seen an impact with regards to rising overdose rates. With limitations in accessing usual care, an ED visit can often be a critical one for these patients. These encounters shouldn't be limited to just those who are presenting with overdose. Consider these critical visits even from harms related or consequences related to substances, such as cellulitis. Remember, our patients are accessing our emergency departments despite fear of contracting a terrifying illness and despite the realization that they might face stigma. By simply acknowledging these limitations and how they're able to overcome to access care, aim to create a safe, compassionate, and trauma-informed space. Consider ways to make your patient more at ease, such as offering harm reduction supplies, management of their symptoms such as withdrawal, and then even just bringing up the possibility of opioid agonist therapy. It can be as simple as offering a take-home naloxone kit, or even offering harm reduction supplies. Oftentimes, we are not the experts in the room. So create connections with local peer support groups in terms of directing your patients, or even asking the patient themselves what they need with regards to harm reduction supplies. Know where your local supervised consumption sites and OPS sites are, where your patients can use safely. We know based on data that still around 40 to 50% of people prefer to use alone. So provide them with patients who do have phones, with the Lifeguard app, or with notifications in terms of letting your patients know where there might be or when there might be a toxic drug supply through drug alert programs such as Radar. And these, as you can see, are harm reduction supplies, and they're often well stocked within our emergency department. Simply ask your patient what they may need. Important to manage symptoms proactively. So order some medications that can help with their symptoms early in their visit, with an example here of an order on the right-hand side. Sometimes you may not be able to give enough for your patient in that moment. There are many other factors at play, and continue to care for them by informing them how and where they may use safely. Lastly, we know opioid agonist therapy can do well with regards to reducing withdrawal and cravings. So bring up the topic at some point in your visit. So why opioid agonist therapy? Opioid agonist therapy has many benefits, including reducing all-cause mortality, but can be difficult to access for many. It does not have to be onerous in your visit, just bring up the possibility. As Dr. Clayman said, initiation of ED buprenorphine is well within our wheelhouse. It's important to be mindful that for some, Suboxone is just not the right time for them, and just bring up the possibility of other opioid agonist therapies that are out there, such as methadone and sustained release oral morphine. It's so important to minimize interruptions in care and with regards to continuing their opioid agonist therapy, and consider ways to facilitate that for your patients, whether or not that's developing protocols to reduce missed doses or creating networks for transition of care with local rapid access or rapid access addiction clinics or medicine clinics or local OAT clinics. In the face of the crisis, novel approaches have been developed, such as prescribing pharmaceutical opioids to minimize accessing the toxic drug supply, such as hydromorphone. It's important to acknowledge that this can be really challenging work, and it's a huge topic to broach in 10 minutes. So here are a few tools to consider to enhance your success. Utilize local guidelines to develop those protocols, as Dr. Clayman said. Consider further education and become an OP prescriber yourself. Again, we are not often the experts in the room, so create local support networks with local providers and addiction specialists when it might be uncertain in terms of what to initiate for your patients. And again, reach out to peers with lived experience to aim to create a safer and more welcoming space for your patients. Thank you.
Thank you, Dr. Miles, for that last presentation. We'll now actually move on to the Q&A session for today's Grand Rounds. So our three speakers who have presented on various aspects of care for patients with opioid use disorder in the emergency department will be on the panel to answer some questions from the audience. But I'd also like to take this moment to welcome two additional experts to the panel. We have Dr. Catherine Dong, who's the Medical Director of the Addiction Recovery and Community Health Team at the Royal Alexandra Hospital in Edmonton. Dr. Dong completed her emergency medicine training and a master's in population health at the University of Alberta. After practicing emergency medicine for many years, her clinical work is now as an addiction medicine specialist on the ARCH team. And we also have Mark Barnes, who is a community pharmacist in Ottawa. Mark, along with his partner pharmacists, are very passionate advocates for the respectful approach to addiction and mental health treatment. He is a member of the National Advisory Council on Prescription Drug Misuse through the Canadian Centre on Substance Abuse, and also serves on the Overdose Task Force with Ottawa Public Health. Thanks to all of our speakers who will be joining us for this question and answer session. So I'll be moderating the first half of it. And our first question is specifically for Dr. Clayman. We have a question from a provider who wonders, where can we get specific resources for prescribing Suboxone in the emergency department? We have all these clinical resources that are, about opioid use disorder in general, but it's hard to find something specific for the ED context. Where would we start?
So CAEP has released the guidelines for opioid use disorder, and there are going to be some tools available as well. There is an organization, at least in Ontario, that is open access called META-PHI, META:PHI, and we will be releasing a number of order sets onto that website for buprenorphine. You can even just Google ED initiation of buprenorphine and get a bunch of different order sets. Or if you want the specific one from our emergency department, feel free to email me and I can send it to you.
Perfect. Thank you for that. Any other resources from our other panelists that you would refer to or use commonly in your practice?
In BC, we have the BC Emergency Medicine Network, where there's a lot of resources available there. And there's also protocols in the States, as Dr. Clayman mentioned as well, where there is protocols available there.
And in Alberta, we have the Emergency Strategic Clinical Network, which has released a whole order set and document suite around starting buprenorphine in emergency departments in Alberta as well.
So we have very provincially specific resources, but we should definitely rely on them. There's not a need to reinvent the wheel and come up with a brand new protocol each time, and consult with the experts we know across the country. Perfect. Thank you. I have a question for Petra. Petra, how can we engage family members of patients we see in the emergency department while also balancing consent and ensuring confidentiality?
I would say start by asking the patient. Often the family will be in the emergency room already, or if the patient joins the family in the emergency room, ask the patient, I see your mom pacing nervously out there. Is it okay if we call her in? Or after we have an initial chat, is it okay if I share some information with your mom? And just follow the guidance of the patient. I know often Danny wanted me there and I wasn't permitted to go in at the ER, and that really added stress. And then he left the ER and said, I have to do a bunch of things. And I said, what do you have to do, Danny? I don't know. Can you ask them? And so kind of the follow through and the tragic consequences that we heard about tonight about somebody not following through on an appointment, you can really improve that when you engage the family. Because imagine the person is overdosed, you just come back from an overdose, they're stressed. and their memory will be affected. So talk to the family and say, here's a list of recommendations. Here's some medication that we could start, and that will really, really improve things. But of course, you start with consent and just with a simple question and take it from there.
I think often we don't even remember to ask our patients, right? Who would you like us to talk to? Who would you like to talk to? What supports you need? I had a patient on the wards who was trying to call his mom in Ontario, and his phone didn't have long distance minutes. And we just had to make that call and forward it to his bedside phone. And he was able to connect with his family and plan kind of his move over there. So
yeah,
definitely
exactly.
benefit our patients. And what are, besides, giving a Narcan kit to patients before they leave, are there any other concrete things we should start doing on our next shift for our patients and their family members?
I think really removing that systemic stigma that is so ingrained in the health system, and also speaking up. If you hear a colleague use disparaging language or stigmatizing language, speak up and stop them, because the initial message you give the person will really determine if they will come back for further care, and if they will go through. If they feel rejected, they will turn away from your department. This costs you nothing. Be kind, be compassionate, and show that you care. And that will make a huge difference in outcomes for people.
Thank you so much. To our physician providers on the panel, are there situations where you've had to educate a colleague or, correct them if they're using stigmatizing language? And how do you approach that conversation? Because that can be quite challenging, right? To say to your colleague, we shouldn't be writing this or saying this. Any examples or advice for us on how we can change that culture in the department? Dr. Dong.
Justin, it's a great question, and the focus of the last 6 years of what we've been doing here at the RAH. It's slow. Culture change is slow, but I think step by step, I think being an excellent role model, I think just pointing it out in the moment, in private, in a very understanding way. Actually, we don't say that anymore. This is the terminology we would use now, and this is why. I think just having those conversations. The other thing I just want to highlight, and picture you had a slide on it, was the National Overdose Response Service. So this is a 1-800 number that's available nationally now, where patients can use under supervision on the phone. So I think that's a really critical resource, along with an naloxone kit to give out on your next shift. We don't have the Lifeguard app in Alberta. So I was really excited to see this resource come out very recently.
Thank you so much. A question for Dr. Clayman. I guess it's a two-part question. The first question would be, what are our options for starting buprenorphine in the emerge if there are limited follow-up options in our community? Let's say it's a community that doesn't have a rapid access clinic. And the second part to that question is, how do we improve uptake of buprenorphine after it is initiated in the emerge? Often it is initiated and we still struggle with follow-up and continuation of prescriptions, et cetera.
Yeah, it's definitely a challenge when there aren't clear pathways where people can go for follow-up after they leave the emergency department. Is problematic. I think finding a local champion at a local family health office or family health team would be really helpful, where you can uptrain the family docs and try to get them to continue prescriptions outside the emergency department, especially in rural areas where there might not be access to addiction service. And I'd love to hear what other people have done. I'm very lucky living in Toronto, where we have a clinic in our hospital 3 days a week. And if that's not good enough, we have a clinic around the corner, or multiple clinics that are open 7 days a week. So we're very fortunate. I'd love to hear what other strategies other people have used. And in terms of uptake, yes, it is very common where people take one dose of something in the emergency department and then don't follow through on the remainder of the prescription. So we're working on this in our department to try to figure out a way forward. But one idea that we have is providing patients with take-home doses, so providing 3 days of buprenorphine or more in some cases to try and at least get them started so they can come back and realize that the medication helps them feel a lot better and perhaps stay on the treatment. Another strategy would be to employ or to engage peer workers in the emergency department to make a phone call the next day or a few days later to re-engage that patient to see how they're doing and to see how we can help them get to their follow-up appointments.
I would challenge as a pharmacist perspective, just to make sure that you probably give maybe a minimum of 4-day supply. More often than not in the situation, especially when it comes to drug use and overdose, is that there is no coverage identified. There may be a lack of access to money to pay for the prescription. It's not a super cheap medication, buprenorphine. That being said, unfortunately, there's been an emotional disconnect between the pharmacy and the client at that point. Remember, 75% of people who overdose have filled a prescription for an opioid in the last 3 years, and at the time of death, about 30%. So there's probably been some problems with opioid misuse at the pharmacy level. So to find a passionate pharmacist to be able to do that, but providing enough medication supply till they can get to a follow-up appointment and or have money or speak to a worker about cash is also very, very important with the continuity of care.
That's something we overlook often, right? We write a script and we don't ask our patients if they can afford it.
That's a really good point, Mark. And something you and I have spoken about is what we can do as emergency physicians and prescribers with respect to naloxone prescribing. And this was something you and I just talked about off the cuff in my office a few weeks ago, but maybe you could highlight that at some high points of what we can do that you've published on recently.
Yeah, so I just finished publishing a kind of a consensus guidelines for pharmacists. So we talked about stigma in the emergency department among physicians, and stigma is real, and it's felt even in Elizabeth and in my backyard, and it is at the pharmacy level. Stigma is real, and even providing naloxone or talking to people about naloxone, it's this consensus guideline was supposed to guide all pharmacists to be able to do this. I would like to see the standard of practice that naloxone is provided with every single opioid prescription. We talk a lot about fentanyl use and illicit use. There is a real problem with prescription misuse as well. Ontario and Canada really is the epicenter of prescribing of opioids in the world, and we because of the amount of opioids prescribed, we really have to do something. So naloxone should be almost mandatory, and physicians should be adding it to electronic EMRs. And if you have that facility in your hospital where if a certain list of opioids are listed there, then why can't naloxone already be printed on that prescription? It's something, little things that physicians, you guys are busy. You don't have to think about it. It's done for you. And it's a really powerful thing. Opioids still are prescribed in emergency departments at times, and it can be a source of overdose, especially for someone who's confused, as Petra alluded to earlier. Maybe there's a little bit of a problem. They're obviously clinically unwell, or else they wouldn't be at emerge. Their ability to take in information and hold it, and then even know how to use a naloxone kit, takes some time. Peer support's an excellent idea, but identifying local pharmacies who are open late and on weekends to be able to be your champions for your emergency department is very important as well.
Definitely building those community connections and partnerships. And we need to be lowering barriers to naloxone kits, right? There's a retrospective chart review from the Royal Alexandra Hospital that showed, for opioid overdoses, only 49% of cases were patients given a naloxone kit before they went home. So we're not really even addressing the low-hanging fruit in the emergency department. So lots of barriers to reduce as well. I remember talking to Dr. Dong about the idea of bringing people back to the emergency department for reassessment, right? We never think about it when patients have to come back for IV antibiotics if they can't be connected to an outpatient, follow-up clinic, et cetera. Why don't we bring patients back? I think that'd be a good option for our rural or small community colleagues as well, right? If you don't have a rapid access clinic, they can come back, register again, and be reassessed and continued on their prescription. That might address the funding piece too for medications, as we can provide it from the emergency department.
And these are real answers that we have to answer, but remember, keep a wide scope. For example, bacterial endocarditis caused by IV drug use. Even cardiologists have to be aware of all this. So the stigma's got to kind of go everywhere. So we have these, the perception. So.
Right. I have a question for Dr. Miles. So oftentimes, we'll have patients come to the emergency department and tell us that they've missed their methadone doses. How do you go about replacing a dose, if at all? And if you're not able to confirm their last dose, what do you do when patients come for methadone?
That's such a great question, and kind of highlights the importance of continuity of their opioid agonist therapy to continue kind of promoting reduction of mortality. So I think it's very much the first tenet is to know what your local guidelines are in terms of dosing of methadone. So in terms of what to do for missed doses, in terms of dose reduction or continuity. With regards to how I would approach it, usually I try and see whether or not their pharmacy is open and try and minimize kind of any barriers to them getting their dose, so long as I've kind of assessed them from that perspective. If I know that their pharmacy is closed, certain provinces have access to kind of provincial medication dispensing, so I can confirm through that and see when their last dose was. And if they haven't had a dose that day, I might consider giving them a dose in the emergency department, and then notifying their pharmacy. And lastly, if I'm not able to confirm, if there's no ability to really safely say that I'm not going to be giving them a second dose that day, utilizing short-acting morphine, as I said in my presentation, can be really helpful and really safe to make your patient feel better until they're able to get to their pharmacy. And lastly, this might be an opportunity to discuss with them a more low barrier opioid agonist therapy, such as buprenorphine. And there are ways to start somebody on buprenorphine, even when they're on a full agonist, as Dr. Kleiman showed, through microinduction.
Thank you so much. I'm going to turn it over to Dr. Scholdeis for our last 10 minutes of our panel for moderating.
Great. So I wanted to ask a question, probably to Catherine and Isabel and Michelle, about some COVID-specific harm reduction. One thing that we're seeing is patients using alone much more often. Isabel, you've touched on this, but if there's a few tiny pieces of low-hanging fruit, we talked about naloxone, and this is probably for Mark as well. So some real COVID-specific harm reduction.
So with regards to harm reduction that's COVID specific, there's been, and that's where I struggled putting it in my presentation, there's been a number of great documents that have been created by peer organizations that are really specific and really great language for our patients in terms of reducing risk with regards to COVID. So even simple things about making sure they could do good hand hygiene, wiping down their substances to reduce that risk. They can still use safely with other people, but keeping in mind some of those restrictions. So staying far away from enough, like at least 2 meters away from the other person. And a lot of patients are worried with regards to the safety of overdose prevention sites and supervised consumption sites. So reminding them that it's safe to access and probably safer to go there with regards to reducing their risk. Again, some people, even prior to the pandemic, were not people who like to use with others. There's lots of factors that contribute to that. So how can they use safely alone? So using that national hotline that Catherine highlighted, if you're in BC, using the Lifeguard app. And then other small things that they can do is testing their dose, so taking a small amount, or even testing with fentanyl strips to see whether or not there's contamination there.
Great. Catherine or Michelle, did you have anything to add for that? It's really helpful.
That's fairly comprehensive and lots of great advice there. The one thing that we have put into place during the pandemic, and this doesn't necessarily prevent overdoses, but we do have now a vending machine outside our emergency department that was requested by the community that has harm reduction supplies. This way they do not have to come into the emergency departments and ask for them. It is out there for them whenever they need it, 24 hours a day. And obviously they don't have to pay anything. It is a free vending machine with various harm reduction supplies.
Another good tool with regards to use alone in your own apartment in different living situations, especially in large urban centers, is motivating tenant boards to be trained on naloxone. There is also a website that we created, naloxonecare.com, where you can go online and get trained. For people living in Ontario and or Indigenous persons in Canada, I can actually send them a naloxone kit in the mail, which is really interesting. So they don't have to go to a site or a pharmacy to get naloxone. The other option as well is that in apartment buildings, they're kind of not in your bubble, but if you wear a mask and knock on a door, say, hey, listen, I'm your neighbor. If, I'm going to leave my door open. And it's, again, the whole stigma thing, though. Self-identifying, I do use drugs at times. I'm probably going to use it tonight. Can you check on me, look and knock on my door in 10 minutes, 20 minutes. And in rooming houses and in supportive living complexes, that works extremely well. In certain apartment buildings, maybe not so much, but certainly having access to naloxone that can be directly shipped to you is certainly an option.
That's great, Mark. I didn't know that that was an option. That's really helpful. This is a question for Michelle, and this is perhaps a controversial sort of hot off the press idea. What are your thoughts on buprenorphine induction after naloxone is given? So if naloxone is given in the pre-hospital setting, I know this is something you and I have attended talks on before, but what do you think about this, and where are we at with this in Canada, do you think?
We're still not sure. I still don't know. There is some evidence showing that it is probably safe to give buprenorphine after somebody's received naloxone, because you've just placed all the naloxone, and as long as it's within the time frame, there might be some opportunity to start buprenorphine at that time. We haven't done it yet, and there's no clear answers. And I'd love to hear if anybody has tried it, because we have not.
It's something that it seems the research coming out of California is really promising, but it's just not really there yet. I'm just going to very quickly jump on my texts here to make sure that we do have a few things. How can we, one question I think for all the panelists is, how can we help improve the uptake of patients to this option? We have very little follow through, even with initiation in the ED and inpatient setting.
One of the things we did, we also had very low follow-up rates to our clinic, which is located right beside the emergency department. So we actually embedded a nurse 16 hours a day in our emerge, specifically with the goal of looking for patients at high risk of opioid-related adverse events, and then taking them to the clinic, engaging them, helping our emerge team start buprenorphine, doing all the naloxone training, providing harm reduction supplies, working with our peer support. And we were able to double our follow-up rates from 20 to 40%, still a ways to go. But still room for improvement for sure. But that was one thing we tried that was successful for us.
Yeah, certainly the use of a navigator, a nurse, social worker is really key for a lot of places. There was some question before about how to get follow-up when it's not available in the community. As you all know now, I'm located in Ottawa, but I'm also working with a First Nations community in the very far north of Ontario they were looking for ongoing support. So 4 of us do telemedicine. So there are options for ongoing telemedicine, OTN or whatever your provincial specific site is. So I think for the family physician, emergency physician, people on this call, you're not alone. There's so much support out there. I just want to encourage people to not see the lack of follow-up as a barrier, because there are many of us who would be willing to provide that follow-up or provide shared care. I think many of us do shared care with family physicians as well. So that's something just to keep in mind. There was one question.
I'd like to make a point about the buprenorphine inductions after naloxone. I think there's not great evidence for it. And I think we need to remember the importance of informed consent, especially for buprenorphine. And I think, in the context of a naloxone-induced withdrawal, patients are often in distress. Can they actually consent to initiation of opioid agonist therapy? I really don't think so, but something to keep in mind as well before we kind of try these experimental approaches, really going back to the patient and asking them what they want.
And I just want to,
sorry, Isabel, you go ahead.
Yeah, I just wanted to highlight as well is that in the States, they often use higher doses of naloxone. They're titrating to a much different effect. And be mindful that we have so many other different strategies where the patient doesn't have to experience that significant degree of withdrawal, and also significantly reducing the risk of precipitated withdrawal through like standard microinductions of 7 days, but also rapid microinduction. So although it could be a promising way to start people quickly on Suboxone, thus far we have other strategies that are probably much more comfortable for patients.
I think the data coming out of California, like you said, is very different, and their pre-hospital care, which is another clinical interest of mine, is very different in terms of the amount of naloxone that they give and how often they give naloxone. I think it's just something to be aware of, that this is happening. You may read about this in journals coming through the emerge literature, but it's a good point that our care is just very different. There was a really good question about fentanyl testing and fentanyl test strips in the emergency department. Note that many emergency departments don't test for fentanyl. So that's something in my own emergency department, 3 minutes down the road from where we are now. It's not something that's standard if you order a urine drug screen. So that's something that requires a lot of education to ensure people understand that doesn't mean that fentanyl is not there. And I think then I'm just making sure we get all the real-time text questions. There are a lot of really kind notes to thank the speakers. And then someone just asked again, how do I approach the outpatient buprenorphine dosing for a patient who is not in clinical opioid withdrawal within the emergency department? So Michelle touched on that, and there are a number of approaches here. One approach is to start a microdosing protocol that needs to be done in conjunction with the patient, talking to them about what that means. There are a lot of resources for how to do that. If that's not something you're comfortable with, you can send a patient home to start themselves once they are in withdrawal, and that's something that's pretty standard. Or you can also have the patient follow up. And I'll get Michelle and Catherine and Isabel to perhaps weigh in on that.
Yeah, I often see these patients in my clinic where they come in and they are actively using fentanyl and not ready to start buprenorphine. And I do pose both options. The traditional way that we would do it in the office setting, which can be certainly done in the emergency department, is to provide take-home doses on day one. So traditionally, we would ask patients to go to the pharmacy every day for observed doses. That's changed a lot now during COVID. And that the practice will vary across the country for that. But I provide 6 2-milligram tablets for patients to take home. So I write that on a script, 6 times 2-milligram tablets to take 2 tablets, Q1 hour, PRN, and that's a maximum of 12 milligrams. So that way, when they're at home several hours later, they don't have to go to the pharmacy when they're feeling sick to get their buprenorphine. They can actually have it at home with them. And then you can decide the following day if that needs to be an observed or a take-home dose at 12 milligrams moving forward. So that's how I do it, just with informed patient consent, letting them know they really do need to be in significant withdrawal before that they start their home induction of buprenorphine at the 12 milligrams on day one.
The other point I'll make about microdosing, and it's something that is very easy. We've been doing it in our clinic for about 2 years now. I do it out of the Emerge, but I often will make a phone call to the pharmacy. Not all pharmacies are yet comfortable with microdosing, and that's something perhaps Mark can comment on. But it's something you need to make sure you have a pharmacist who's on side and knows how to do this. It's not super technically easy from a pharmacy point of view. So just something to be aware of, that you want to connect with your allied health professionals to make sure you're doing that appropriately.
It is, it's not hard, as Liz alluded to. It's not hard for a pharmacist to do this, and we can actually do it. And it's actually more often than not makes a patient who has used opioids significantly feel more comfortable that they're not going to have to experience any days of withdrawal before they start OST. That being said, here's a problem we see in daily pharmacy or in pharmacy in general. There is a ramp up dose that's quite regimented for success based on research. If there's days missed halfway through the process, you got to have a protocol in place of what do you want the pharmacist to do at that time. Lots of times you guys are not available for us. Not always. Liz is lovely. I can certainly get a hold of people. But in general, you want to make sure you make that connection with the pharmacy, have fantastic communication, whether it be text or email, that if day 3 of a ramp up on buprenorphine is missed, that you can, would we go back to day 2? Do we hold steady? What do we do, right? And pharmacists are sticklers at times on policy procedure. It has to be written correctly, right? So you want to give some direction about what to do if a dose is missed during those 7 days based on work, scheduling, different things. It's important to know.
That's really great, Mark. Thanks. Thanks for the shout out. I try to be available. Just the very last comment, and I think this is really important for emergency physicians to be aware of across the country. If Michelle or Catherine or Isabel could weigh in on safer supply.
So in terms of just to maybe just jump onto the microinduction thing, I write on my prescription just to stop and redirect the patient to the clinic to reassess dosing, because there is a lot of variation with regards to protocols, but a lot of that upfront education is so important. And another way in terms of promoting patients with regards to home inductions is actually setting up a program within your ED where they leave the ED with a 3-day supply of buprenorphine. So you're taking out that even initial step where they're able to feel more comfortable to start at home. So with regards to safe supply, there was a clinical guidance document, at least in BC, with regards to recognizing that our patients are at high risk for multiple reasons with regards to overdose, but also contracting COVID. So reintroducing or introducing the possibility of prescribing pharmaceutical opioids to reduce accessing toxic supply. In my practice, we're often giving it in conjunction with opioid agonist therapy to facilitate particularly your long-acting ones, knowing that initially it's not enough. And I also found it quite successful with regards to microinduction, because those first couple of days, the Suboxone just isn't quite enough to address their symptoms. So the data is still pending with regards to the results with regards to overdose rates, but there was a recent CMAJ article in the last year showing that less than 2% of overdoses, at least in BC, were linked to prescribed opioids. So I think it might be another tool in our tool belt to get people to, be stabilized on opioid agonist therapy.
Yeah, and I think in Ontario, it's very important for emerge docs and across the country to be aware that these safer supply programs are happening. It is quite controversial within the addiction medicine community because there is concern around diversion of the fentanyl tablets and questions around whether or not it actually reduces illicit fentanyl use, and concerns around increased infection rates. So there is a bit of a divide, but it is being done in Ontario, in Toronto. There are several sites.
I can speak to, I'm a part of the Ottawa the Safer Supply bid. It's in conjunction with many CHCs as well as a couple of private clinics here in Ottawa. We have 240 patients on Safer Supply right now, currently. Data is still pending. It's being studied now and hopefully to be released actually very soon. So we'll have some of that data, robust data for Ontario as well. We are seeing a very small rate of overdose right now anecdotally, but the evidence will be there. And the diversion is not as robust as you would think. It's actually decreased the value of hydromorphone. The value of hydromorphone is essentially nothing anymore in Ottawa, which is actually unique. And the fentanyl use is extremely decreased with regards to patients among the safer supply programming. The other wraparound care models that you'll see, hopefully in the data soon, is actually wonderful as well. So yeah, emergency room docs, please have a heads up for a person who's actually on hydromorphone. If they missed that appointment, and you may want to connect with the local safer supply program in your area, so you know who to contact to say, hey, you've gave continuity care, kind of like methadone. Maybe you've gave some Dilaudid as well, and they all do have long acting as well here as well. So more of an OST feel as well.
Yeah, it's great to hear that we're going to be hearing more evidence. We should be aware of it when we're in the emerge, because patients are getting up to 24 8-milligram tablets of hydromorphone daily dispensed from the pharmacy. So if we're not meeting their opiate requirements when they come in, they're going to go into withdrawal and are at high risk of leaving against medical advice. And one place it's being used a lot is in the COVID isolation hotels, where people who experience homelessness are now being housed, and in the COVID query hotels and in the COVID positive hotels for the people who experience homelessness, to help prevent their fentanyl use and transmitting COVID. So it is very now common across the country.
That's great. I think we'll leave it there. This has been an absolutely excellent discussion. There's been stuff coming across Twitter as well. I'd like to sincerely thank all of our presenters, to Justin, my co-moderator, and Justin, who did the lion's share of the work in coordinating the speakers. This has been just tremendous. Thank you so much to everyone for offering their expertise to us this morning, to the CAEP staff who put this on, to our producer who tied everything together and made this look much more professional than I think we ever could have done on our own. I'd just like to give a little plug to the next CAEP Grand Rounds, which is called STEMI-ish. David Carr is one of the presenters. He's one of my favorite emerge presenters. I always learn a lot when he speaks. It's very engaging. Thank you all for the really excellent, good work you're doing for our patients across the country, and for the advocacy you're providing. A lot of lives saved with the things that you're doing. So thank you so much. And we're available if there's any further questions. Reach out via CAEP. And I think that's everything. Justin, was there anything that I missed?
No, thank you so much to everyone for joining us today.
I'll probably sign off with the requisite wave to Zoom, which I can't stop.